So Rishi, we really appreciate you joining us, mate. It's very decent of you, and we'll get going with we'll play the video. And he's here for chat questions.
Good evening, everyone. My name is Rishi Dhir, and I'm a consultant based at the Princess Alexandra Hospital in Harlow. And I'm here to talk to you about some top tips to pass the FRCS. And this is something I really focus on in my teaching company, Let's Talk Doctor. So I was really happy for Pete and Cash to ask me to speak to you guys today. Now, I'm going to give you not only some top tips to pass the FRCS, but hopefully to smash the FRCS, because that's the attitude I want you to go into this exam with. No fear. A quick disclaimer, all opinions are strictly my own. Everybody's an individual. So I'll give you some tips today, but it's important that you bring your own personality and ideas into the exam as well. And I don't apologize for any controversies yet. So I'm going to speak to you about a few of my commandments. And unfortunately, because of time constraints today, I can't tell you about all of them, but I'll give you a brief flavor. So firstly, thou shalt dispel the myths. Now, the FRCS is a really difficult time in your life, and there's lots of mythology that exists around it and sort of irrational fear. But I'm here to tell you to dispel some of those myths today. Firstly, knowledge is the most important thing. Well, actually, no. Part one, the MCQs are a knowledge exam, but part two is more about principles and technique. So that's the most important part of this exam. Secondly, the FRCS Orth is difficult. Well, actually, the questions that you'll get, the so-called 90%ers, as I call them, the majority of them are things you meet in your day-to-day life, such as cauda equina, carpal tunnel, CMCJ arthritis, things that are very commonplace. And actually, the weird and wonderful, the skeletal dysplasias, people very rarely fail on those. And actually, the FRCS is often as difficult as you make it. And finally, the FRCS is an exam. I'm here to tell you that it is not an exam. You might think he's crazy, what do you mean? But I'm here to tell you, go into it with a different attitude. So firstly, mano a mano, you're the candidate inside the cage and you're trying to stay in shallow waters. Face danger head on, be alert and don't bleed. Don't give the examiner, the great white shark, an opportunity to come into that cage. So try not to say silly things. The candidates who I've seen get into trouble are the ones who talk themselves into trouble in the exam. So it's important to stay very generic and also safe in your answers. I told you it's not an exam, and I stand by that. This is a job interview. They are looking upon you at the other side of the table as a colleague, a day one consultant. So it's important to think of the examiner as a colleague who you're having coffee with and a day-to-day discussion, because a lot of candidates go into this thing where they start fearing the examiner and they start talking to them as if they're their senior. It's important that you speak to them with respect, but also as if they're your colleague and you're talking about a day-to-day case. And it is important that you stand out, but in a good way. Second commandment, thou shalt compartmentalize the way ahead. Now, you've only got 5 minutes in this exam. And when you go into this exam, you've got about 10,000 facts in your head. It's a big jumbled up mess. So it's important that you take that mess and you convert it into a series of compartments, which are much easier to recall. So I call that compartmentalization or signposting. And what I mean by signposting is where you give your subheadings to the examiner ahead of time, so you can then talk through those subheadings. And it has twofold positivity. Firstly, the examiner is obligated to let you talk about those headings. So you are now in control of the viva. You have the so-called higher ground, if you're looking at the Anakin Obi-Wan analogy from Revenge of the Sith. Secondly, the examiner will often say, tick, and get you to move on so you can get on to a further opportunity to score marks. So let's give some examples of compartmentalization or signposting. Open fracture management. Well, I would divide this up by saying, having resuscitated the patient appropriately, I would divide my management up into 3 distinct stages. Firstly, immediate wound care in A&E. Secondly, the first debridement. And thirdly, definitive fixation of soft tissue cover, which may or may not be done at the same time. Tell me about bone or cartilage. Well, I break it up into bone is a composite material which consists of organic and inorganic components. It can be thought of at both the macroscopic or microscopic level. And I would then break it up into organic and inorganic. a titanium nail. So you could talk about the formula of titanium and then break it up into composition, manufacture, properties, and uses. And I would use that for any biomaterial. Principles of tendon transfers, break it up into patient factors, donor, bed, or recipient factors. And finally, you're a new consultant in a hip unit with a high infection rate. Break it up by saying, firstly, I would stop operating, do no harm. Secondly, I would do a root cause analysis to see if the problem is at the patient, surgeon, or implant level. And finally, I would institute change, dividing it up into pre-op, intra-op, and post-op. So if you're not sure of how to compartmentalize, some default type things you could use are break it up by chronology into pre-op, intra-op, and post-op. For example, a Paget's total hip replacement or theatre precautions. By cause, patient, surgeon, or implant factors. By guidelines, such as Bose guidelines. Or by number or anatomical site. For example, nerve compression. Third commandment, thou shalt be frugal with thine words. Going back to what I said before, this is a 5-minute station, whether it's a short case or a viva, or if it's an intermediate, it's 3 5-minute parts, okay? So every single word that comes out of your mouth cannot be waffle. It's got to score you marks. So it's really important that you know the buzzwords, and effectively, you can summarize things very quickly because they are looking to tick things off. And whenever I go into an interview, I think of 3 words to summarize every topic, or these key words. So I'll give you some examples here. This is a Charnley or composite beam type prosthesis. So the key words would be a 3-point fixation, a single unit between stem, cement, and bone, and stress shielding. This is a triplane fracture. So the key words would be a Salter-Harris 4, a 3 in the AP, a 2 in the lateral. It's a transitional fracture, and it's caused by differential closure of the physis. An MRI scan. Buzzwords would be nuclear spin, longitudinal and transverse magnetization vectors, and precession. An Exeter hip or a force closed hip. Buzzwords would be polished double tapered, controlled subsidence, and hoop stresses. So very quickly, I've summarized a big topic in just a few words, which I will then go on to explain. Commandment 4, thou shalt structure thine answers. And this builds on what I've already said about compartmentalization and buzzwords, but let's take it that step further. It's really important, guys, that you know the scoring system when you go into the exam. And you might think, well, Rishi, that's being a bit noddy, but it's amazing how many people forget the scoring system and don't keep to their timing targets. So you can score effectively 4 to 8. Now, you're having to do either very badly or very well to score a 4 and an 8. So the majority of people are going to score the 5s, 6s, and 7s. And I want to get you up to the higher end of that rather than the lower end. So you've got to show evidence of higher order thinking, okay? So it's really important that your opening gambit, the first 30 seconds that come out of your mouth, pretty much determines your grade. If you say something very intelligible, you've passed and you're going on to a 7 and an 8. If you say something disastrous, you're pretty much on a 5 and you're spending the rest of the 5 minutes trying to recover that up to a 6 at best. So it's important to know your timing targets. And so remember the film Saw, the opening gambit, do you want to play a game, is the key. So I've made a great mnemonic for you guys for this, the 5 Ds of deer that you can take into your answer to score an 8 in the FRCS exam. So the first thing is, whenever you're given any prop in the exam, describe it. And so I always have an opening phrase. If it's an X-ray, this is an AP and lateral radiograph of the pelvis in a skeletally mature individual. It shows. This is a clinical photograph of both limbs in a child. It shows. This is an explanted specimen of a tibia. It shows. Okay, and when you describe something, you can describe it in terms of lower order thinking, a 5-6. For example, this is a subtrochanteric fracture of the right femur. That will only ever get you up to a 5-6. Or you can show evidence of higher order thinking, where you're not just thinking of the diagnosis, but the subsequent management. There is beaking of the cortices, there is thickening of the cortices, there is loss of corticomedullary differentiation. So not only is it a subtropic fracture, it's likely to be pathological, either Paget's or a bisphosphonate related fracture. That's the higher order thinking. Diagnosis, come to the diagnosis within 30 seconds, okay? You need to be hitting that time for that. Discussion. So I always think about this, guys. The discussion is you're driving along Route 66 and you're trying to reach your nirvana, the gold at the end of the rainbow. But as you pass Route 66, you're seeing the shit on the side of the road, history, exam, investigations. Now, you have to acknowledge the shit, but you don't want to get stuck in it. So that's why you need sort of buzzwords to get you through this, okay? So I would take a pertinent history, asking about risk factors and how the condition affects the patient. Be specific. Don't just say, I would take a history. No, I would take a pertinent or focus history, asking these questions, okay? Decide what is your actual management plan, and you need to be hitting this by 2.5 minutes. And most of the time, they are looking for operative management by 2.5 minutes. And finally, diagram, if you can, usually in the basic sciences. Detective, show some evidence, show some evidence to back up what you're going to say. Or discussion. Many FRCS questions have a discussion point. And that's how you score an 8 on FRCS, the 5 Ds of Dear. So for example, putting this into practice, that's an open fracture. I've already described how I talk about it. So I'd say this is a clinical photograph of the femur, which shows a completely denuded bone with extensive periosteal stripping. So it's at least a Gustillo and Anderson 3 open fracture, although I will formally be able to classify this at the first debridement. Higher order thinking and diagnosis. Discussion. So I'm going to talk about my immediate wound care in A&E. First, immediate wound care in A&E, so I'll talk about tetanus, IV antibiotics, etc. Decision making. So how are you actually going to manage it in theatre? Okay. And then finally, evidence, detective, boast 4 guidelines. Okay. Rotator cuff arthropathy. The buzzwords as I'm going to use is loss of acromial-humeral distance, femoralization of the humeral head, acetabularization of the acromion. Okay. Discussion. You're going to look at patient factors, disease factors. This is end-stage disease. Decision making. Okay, you might start with a suprascapular nerve block, but ultimately the only definitive treatment is going to be a reverse. And this will be a complex reverse because you've got extensive bone loss, retroversion, and loss of the acromion as well. Okay, and you can talk about evidence in terms of reverse for management of these conditions. Okay, commandment number 5, thou shalt work out where the question is going and lead the way. So when I answer an FRCS question, I always think there's 2 ways of answering any question. Pitter-patter is where the examiner will say something to you, you'll give something short and sharp back, and it will be a back and forth, and you'll never score more than a 6. Lots of prompting is required. Now, sometimes pitter-patter can be useful. So, for example, I was weak at skeletal dysplasias or tumors, so I was happy for the examiner to guide me through, score no more than a 6. But sometimes you know where the question is going, and so you can do something called anticipation and guidance, where you take the examiner through the answer yourself. Yes, you won't talk for 4.5 or 5 minutes if they stop you, but if they don't, then by all means, take them down the route of where it's going to go. So for example, this came up in my exam. They asked me to talk about this, and it's got a very clear route of where it's going, okay? This is a DEXA scan, so you want to know how it works, talk about T-scores and Z-scores, what it's used for, osteoporosis, what is the WHO definition of osteoporosis, what are the guidelines for treatment, and the final question will always be, how do bisphosphonates work? So rather than working forward, I think of the last question and I work backwards. This is a perilunate dislocation. So the last question is going to be median nerve compromise or tendon transfers. So working forward, I'm going to think about Mayfield's classification. I'm going to think about checking the median nerve, closed reduction in A&E, that fails. Do I take them in the middle of the night or not? Closed reduction in theatre, open reduction in theatre, and definitive fixation. Commandment number 6, thou shalt beware the pitfalls. Now, guys, there are some questions where if you say something silly, it will be there to try and fail you. It's what I would call the pass-fail question. So you've just got to be aware of these. I'll give you some examples. So this is a 55-year-old gentleman who's been on the medical wards with hyponatremia, complaining of pain the last few days. The medics take an X-ray and ask you to see the patient. The failure mistake, as we can see here, light bulb sign, a posterior dislocation. The failure mistake would be to say that you would reduce it in the middle of the night. Why? because if you didn't get further imaging, you'd hear a big crack. And that's because anybody who's got a posterior dislocation of unknown chronicity is a locked posterior dislocation until proven otherwise. So you must get further imaging in the form of an axillary view or a CT. Otherwise, you've got the potential of causing a proximal humerus fracture with a closed reduction. So that is a failure mistake. Commandment number 7, thou shalt know the rules and stick to them. And we're coming to the end now, okay? So, know the rules. You've always got to stay in shallow waters. Don't go complex. Start simple first and then go complex. So what I mean by that is you cannot score the 8 before you've scored the 6. And the 6 is always the safety question. They want to check you're safe first. So for example, in a unifacet dislocation, you need to talk about getting an MRI and referring to the neurosurgical unit before you start going on about evidence and Smith-Robinson approaches, etc. Start simple and then go complex. Listen to the question. How would you manage this? Not what are the 10 options? How would you manage this specific patient? So even if they've got a smashed up calcaneal fracture in a 25-year-old, if it's someone of no fixed abode, IVDU, high smoker, diabetic, you're probably going to treat this non-operatively, even though the fracture might suggest that it needs fixation. Or at best, you'll do a percutaneous fixation and minimize soft tissue stripping. Don't argue with the examiner. Now, you can have a disagreement. That is by all means acceptable, particularly in the trauma viva, but don't argue. Even if the examiner is wrong, just say, okay, thank you, and you can move on to the next part. You can pass or recant, but I would say once or twice, not all the way through your viva. So if you say something stupid, don't keep going down the rabbit hole into Wonderland. Stop the examiner and say, I'm so sorry, I've made a mistake. Can I please recall? So finally, guys, take a leap of faith. You're all going to be great next week. Don't be afraid. Remember the 90%ers. Try and know those common questions the best, because that's what's going to decide whether you pass or fail this exam. Now, I could only tell you about a little bit of stuff today, but if you have any further questions, please feel free to email me on letstalkdrrishi@gmail.com. Check out my website, or I'm also on Twitter or Facebook. So please smash a like on that and give me a shout. And these are some of our courses that we do as well, including the Blitz course coming up in a couple of weeks for people doing the June exam. So thank you very much. I wish you all the best for the exam in a week's time. And I'm sorry, Pete, I've gone slightly over there as well. But best of luck, guys, for the exam.